36-year-old female complaining of distortion in her eye. She has multiple comorbidities on levodoxal and anticoagulant. That's her OCT scan. You can clearly see the retinal membrane on the surface. Started by routine vitrectomy, started a PVD induction. As soon as I started PVD induction, you can see the hemorrhage at the disc. There was no touch or anything, it's just the vitreous moving, and now taking the rest of the posterior hyaloid, lifting that up, and again the bleed is actually worsened, started to stain to start my peel. And that's a closer view, so started to peel very closely, and then as soon as I touched the membrane, bleed, I tried to get that again, it continued bleeding, and then in the end I decided to just grasp on a different area. So I completed my grasp from a different area, and that wasn't a huge bleed like the last grasping area. I pulled the rest of the retinal membrane, and as soon as I started to pull the membrane, as you can see, another bleed. So I concluded my peel. I removed all the membrane, including the ILM, and peeled the rest of the ILM. And then, as you can see, the blood, I started to try to remove the blood, and that blood was very close to the retina. I decided not to go and remove the rest of the blood very close to the disc. And that was the post-operative appearance with the membrane removed. And still, the focal contour is still not back to how it was, how to normal place. But yeah, that was my case.
Very good work, Sharif. Before the session, you told me if anything happens to Sharif, no dinner for you tonight. So I think that the first thing, of course, once you know the history with the bleeding tendency, you must control that, especially in an elderly patient. You don't know what happened inside the eye. And once you start seeing the blood, then I wouldn't continue. I would start seeing first how to control the blood, either working the full procedure under increased intraocular pressure, and making sure I don't have blood. Actually, the blood is more harmful than the retinal membrane. And if you plan removing the internal limiting lamina, once you have blood clots inside the eye, it will come off with the blood itself. So I will start peeling outside the blood and leave the blood to the last step if it happens, and just peel it with the internal limiting lamina. But the most important thing is preventing it from happening. Before the case, that's decreasing the blood thinners and making sure that he has no bleeding profile. Intraocular, once it starts, you start controlling the first spot that you have by the intraocular pressure. Make sure that he's not hypertensive at the same time. I always ask the anesthesiologist what is the pressure in each step once I start seeing hemorrhage inside the eye. Maybe the blood pressure is too high. Maybe the blood profile is okay, but the blood pressure is a little bit too high. But at the end, it looks nice.
So usually, as a routine, we never stop. Blood thinners actually in the UK, it's the routine.
The other drawback is the patient must have hypertension. Sometimes when you look at the monitor, you find her 180 or whatever, so she's bleeding from the hypertension more than the blood thinners.
Sharif, was it under local anesthesia or general?
On the subtemal block.
Subtemal. Sometimes the strain of the patient during local anesthesia can get this elevation of the pressure, and you say you don't stop anticoagulants before surgery? All anticoagulants, or like Comarine, even those they don't stop?
No. The only thing is maybe if it's a routine surgery and we're using maybe heparin and the INR is above 3, we might consider, but that's just for routine surgery, not for like diabetic.
We know PVD by itself can induce splinter hemorrhage on the disc, and particular hemorrhage that can occur during the ILMP even without touching the retina can occur, but when there is massive bleeding tendency, the clot enlarges, and as we have said here, you peel the limb from a different direction, take it, and this will take the clot with it.
Sharif, excellent. I would have done the same. I would peel from away from the papillomacular bundle, because then you're also away from the disc and the vessel and the nerve fiber there. But this is really excellent, and it's good that you left the clot there. So you're right, we'll have to move on. Sorry, Kevin. Thank you. And our last but not least, definitely a speaker is Dr. Zofia Naroga from Poland. And Zofia, Okay, thank you so much for presenting.
Thank you very much. I would like to present you a case. It's running. A case of recurrent retinal detachment sent over for repeated surgery, and as you can see, during retinotomy, I created some subretinal bleeding, and as we know, subretinal bleeding is always a risk factor for future formation of subretinal bands. And first of all, we have to get the blood out of the fovea, so we cannot allow it to come to the fovea. Of course, to stop the bleeding, we can use diathermy, increase the intraocular pressure. You can see that I removed the blood from the subretinal space, and the retinotomy is already created, but still we must think about the fact that afterwards some subretinal bands might be created. So in my opinion, that is like an ideal candidate for future methotrexate use.
Very nice case, Jofia. I think that the hemorrhage came from the choroid, hitting the choroid, not hitting the retina. So you did perfectly in dithermizing the retina in the beginning. That's point one when you plan doing the retina. Point two is always injectable fluorocarbon, because if it happens, it will start going back. So maybe I would increase the bubble of the fluorocarbon a little bit closer to the tail before attempting doing this. Third point is I never cut in the periphery where I can't see good. If I'm too peripheral like this, maybe I will do a little bit of indentation so the tissue comes in the center lens so I can see where I'm cutting. But I think it happened mainly from the lower part of the scissor. It hit the choroid in that area. At the end, you see it coming from the choroid or the retina.
Completely agree. It might be the reason. Yeah.
Well, how you manage it is the most important part. I think that's a teaching point for everybody. You have to protect the retina. Once you're doing vitrectomy, you always have perfluorocarbon to prevent any blood that might happen once you're planning vitrectomy, going to the back part of the eye and having good diathermy at the edges that you're going to cut. That's very important. And if it's so peripheral, do indentation so you can see the tissues that you're cutting at the time. And of course, some people like the cutter, but the cutter usually cuts a lot of retina. You can use the scissor you should. The force of the vertical scissor, you always press it directly. So this breath can cause the lower plate to hit the choroid, not touch the cutting breath. But an excellent case and very well managed at the end. It looks very nice.
Thank you.
Thank you so much. And for the sake of time, we have to conclude the session. Thank you. Oh yes, so we still do have Dr. Khasafi. Okay, go ahead. Online, can we get him? Okay, here he is. Helen, you look great.
Thank you. I'm sorry I cannot make it with you guys. I'm sure you have a lot of fun and great time together.
Indeed.
And thank you, Ashraf, for inviting me and disturbing my vacation.
Can we have Dr. Safi's video, please?
It's a narrated video, so I hope you can hear.
Yes. It should be the last slide. Yeah. The very last slide. If you go to
not this one.
The very last slide, the black one. Sorry, آخر واحدة, آخر شيء.
As in this particular case, which I'm demonstrating of diabetic traction detachment. In this 23-gauge vitrectomy, a reusable horizontal scissor was inspected prior to introducing it within the eye. It was introduced with a closed plate. I noticed the residual membrane fibers at the tip of the scissor. When I tried to use the scissor, I noticed that the blades were open and not closing. I decided to replace the scissor, but was unable to remove it from within the eye with widely open plates. The unexpected behavior of the scissor may result in surgeon frustration and panic, which in turn may lead to more problems. I had to stop trying to remove the scissor and look into the problem closely to understand what went wrong. After a while, I realized that the blades were not closing because the right blade connected to the left blade. Care should be taken not to break the blade, which may lead to serious retinal damage. Several attempts of pushing the right blade through the light bulb were not successful. The other option is to remove the trocar and extend the sclerotomy into 4 to 5 millimeters to remove the widely open blades of that scissor. This seems to be more traumatic and may cause serious damage. Therefore, reversing the locking mechanism would be a better option. I had to unlock the blade by placing the light pipe between the blade and turn the scissor handle clockwise while squeezing the handle. This trick solved the problem and the locking mechanism was reversed. Finally, the scissor was removed without any undesirable complications. This unexpected behavior of this mechanical instrument can occur with any instrument. It can be avoided by better inspection or using a disposable instrument.
This is Dr. Khaled Sabti, and thank you for watching my video.
Shukran Dr. Khaled for sharing us with this rare complication, but I wonder, even in Kuwait, reusable instrument, use it more than one time?
This is a reusable 23-gauge scissor.
Not a brand new.
No, it's not a brand new, but it is reusable, so you can basically re-sterilize, you can use it. This video is 10 years old, so now we moved 100% to reusable, to disposable, but this is at the time, and as you can see, it was 23 gauge, and I rarely use 23 gauge retractor now. But this at that time we were using the reusable 23. This is the scissors that you just. It's a common handle that you change only the tip between scissor, forceps, vertical scissor, island forceps, you know. It was very famous or known brands that those days where you just change the tips. And that was one of them.
I think that I was not very happy all the time with those type that you change the tips. I think that if the machine is dedicated for one purpose, it's more effective than if you just plug and unplug and use different options. But you managed properly this case. The only option was to remove the cannula, enlarge the incision, but definitely you have done the right thing to take it from a small incision without jeopardizing the vitreous space.
My concern with like a lot of manipulation, and you can see you can easily damage or fracture one of the blades, and guess what? It will go directly to the macula, you know, and that is it can cause serious problems. So obviously that went well, but as you said, alternatively extending the scissorotomy and getting it out without breaking it.
Thank you so much, Dr. Sabti, and so sorry for disturbing your holiday. It's fantastic having you with us here.
Thank you very much. I wish I was with you.
Yes, thank you so much.
Enjoy the rest of the meeting.
Dr. Khaled, where are you? Dr. Shah is asking.
I'm in Antalya.
He's in Antalya. All right. Excellent. Thank you so much, and thank you so much, everyone. I'm sorry that this session ran long. Thank you. Thank you for the speakers, and thank you for our referee.